Good evening to everyone. Today, welcome to the new onset of refractory status epilepticus, the program by the Yashoda group of hospitals. We are doing every Tuesday the academic programs. Every weekly, we are taking a new theme. And this time the theme was there from the neurology. And that is the day-to-day problem. Most of the patients will come to the hospital for us, either because of the trauma, either because of the patient having an infections or patients having a traumatic brain injury. We find out some patients are getting seizures. It becomes very difficult and their outcomes are devastating. To bring this case, we are having an eminent speaker, our colleague, Dr. Nithin P, who is the consultant, the intensivist at the Yashoda group of hospitals at Hitec City. Followed by Dr. Durgesh Satalkar, who is a senior intensivist at Yashoda Hospital, Secunderabad. He'll present the discussion about NORSE. I'll request Dr. Nithin to go ahead with the presentation of the case.
Thank you, sir.
PPT.
So good evening, everyone, and thank you for the brief introduction. So I'll be discussing a case report. So this patient has been admitted to our ICU. So coming to the case, so we have a 32-year-old pregnant lady who is gravida 3, para 1, living 1, aborted 1 with 15 weeks of gestational age, who is a lecturer by profession hailing from Hyderabad. She got admitted to our ER on 31st May 2023. So she came with the complaints of generalized tonic-clonic seizures of 2 episodes, which lasted for 10 minutes with unresponsiveness. And she also had a history of headache since 1 week. So initially, before presenting to us, she went to a local hospital with those above complaints, and where she was treated symptomatically with injection midazolam 2 mg stat and injection levetiracetam 1 gram IV stat. Following which her symptoms subsided, and there was a EEG also was done, which was normal. So later she was referred to her hospital for the further management. During the transit also, she had 1 episode of GTCS episode. So she has no nil comorbid and no drug history. Her obstetric history was she's gravida 3, para 1, living 1 with a 4-year-old male child, and aborted 1 because of cervical incompetence during first pregnancy. And she had a history of cervical stitch in the second pregnancy. On examination in the ER, vitally her BP was 100/60. Heart rate was 80 and saturations were 97 on room air, and her sugars were 116. On neurological examination, her Glasgow Coma scale was E4, V4, M6. She was conscious, confused, following simple commands and moving all 4 limbs. Her pupils were bilaterally 2 mm, reacting to the light, and there was no rigidity, and she was afebrile. On per abdomen examination, on a uterus palpation, it was 14 to 16 weeks of gestational age, relaxed, and the fetal heart rate was 140 beats per minute, which was normal. So in the ER, all the necessary lab investigations were sent, that is a CVP, LFT, RFT, and she was started on injection levetiracetam 1 gram BD with IV fluids and other supportive care. Later, she was shifted to the ICU for the further treatment. Upon arrival to the ICU, within 15 minutes, she had 1 episode of focal seizures on the face with uprolling of the eyes, which lasted for 10 seconds. Which settled gradually with injection levetiracetam 500 mg stat, following which she was in a post-ictal confusion, drowsy but arousable, not following commands. She was maintaining her airway, and vitally she was stable. So we went on with an imaging study where we got MRI brain done with MR venogram to look for any structural lesions in the brain. In the MRI brain, we could see there is no lesion or anything. And in the venogram also, we could rule out CSVT in case of this study. So this was a normal study which was done. So on the day of admission, her baseline investigations were CBC was hemoglobin is 10.6 gram percentage. Total count was 12,150. Her RFT and serum electrolytes were normal. LFT was normal. Serum calcium incidental was found to be 7.68 with albumin of 3.22. But the corrected calcium came out to be 8.3, which was near normal. Her serum magnesium levels were 2.86. And on complete urinary examination, pus cells was 19, leukocyte esterase was 2+, which was asymptomatic. And her 24-hour urine protein was 253.86, which was done to screen for any preeclampsia, which was less than 300. And necessary urinary cultures were sent from the ICU. So on day 2, her vitals were stable. She was maintaining her airway, her hemodynamics and vitals, everything were okay. And the labs were also normal. But in view of her persistent seizures, she was started on injection magnesium sulfate 4 gram in 100 ml NS stat, and injection phosphonatoin was started along with levetiracetam. That was 1 milligram stat, 1 gram stat, followed by 100 milligram TID was given. But even on magnesium sulfate, bolus dose, and levetiracetam and phosphonatoin, her seizures didn't subside. So a third anti-epileptic was decided to add, that was phenobarbital, 1000 milligram in 100 ml NS for 1 hour, followed by 60 milligram TID was added. Along with that, a continuous EEG was connected to her, and in view of her drowsiness and all, so a rail tube and Foley's catheter was secured. So this is the EEG finding, which was on day 2. Here we could see this even numbers are on the right side and the odd numbers are on the left side. On the 24-hour EEG, we could see multiple epileptiform discharges, and they were more on the left posterior quadrant more than the right posterior quadrant. So this was a clip of the 24-hour EEG, which we could get. So on the right, we could see the epileptic discharges, and on the left also, we could see some discharges in both the pictures. So later on day 3, her seizures continued. On the EEG also, we could find persistent seizures. So a diagnosis of new onset refractory status epilepticus was made. And later, the family has been counseled regarding the clinical status and regarding the exposure of fetus to multiple anti-epileptic drugs. And the decision was made to intubate the patient in view of her drowsiness, to secure the airway, and also to start injection midazolam as an IV infusion, and also to go for a CSF analysis and send the CSF for cell count, proteins and sugars, ADA, autoimmune profile, meningitis panel, serum autoimmune profile, and anti-TPO antibodies, and a thyroid profile. So the CSF has been done, the airway has been secured, hemodynamics are maintaining, and the CSF reports came out, proteins to be 27, which were normal, sugars are 88, and the WBC were 5, which was looks like a normal CSF study. So on day 4, she is on 3 anti-epileptics, that is levetiracetam, phosphonatoin, phenobarbital, along with the anesthetic agent, that is injection midazolam infusion. On examination, her GCS was E1 VTM2. She was drowsy, not following commands. Vitals wise is stable. Labs were within normal limit, and the gynec team had checked the FHR, which was around 140 beats per minute, which were present and normal. And the continuous EEG was ongoing, which showed a persistent seizure activity. So this is the EEG, which was on day 3, where we could see even on 3 anti-epileptic drugs and midazolam infusion, we could see persistent activity on the right and the left quadrants, on the fronto-temporoparietal regions and all. So empirically, we thought to start her on IV methylprednisolone 1 gram IV slowly, because the turnaround time of autoimmune encephalitis panel in our hospital is around 5 to 7 days. So a plan was to start her on IV methylprednisolone 1 gram. This was on day 1. So on day 5. So on day 5, we could see the seizure activity has slightly come down, and we thought to plan to wean her off midazolam infusion. But when we're trying to wean her off the midazolam infusion, we could see the EEG again showing a cluster of seizure activity. So we went on to add a second line of second anesthetic drug, that is injection ketamine, at a dose of 2 milligram per kg loading dose, followed by 1.5 milligram per kg per hour infusion with a continuous EEG monitoring. And a second dose of IV methylprednisolone 1 gram IV was given. With empirically, she was started also on injection aceclidine 750 milligram TID to rule out any, if we thought we missed out any viral etiology. And on the day 6, she showed persistent epileptiform discharges with the triple AEDs with dual anesthetic agent. So the ketamine dose has been escalated to 4 milligram per kg per hour. And empirically, we also started her on IVIG, that is 0.4 gram per kg per day, along with a third day dose of IV methylprednisolone. Later on day 7, we could see her GCS was E1 VT M1. Vitals are stable. Labs are within the normal limits. And continuous EEG was persistently showing the epileptiform discharges. So along with midazolam and ketamine, even after increasing the ketamine dose, we thought her to start her on propofol infusion, and along with IV AG and steroids, where she landed up in supra-refractory status epilepticus with triple AEDs and triple anesthetic agents along with IVIG and along with steroids. So the CSF and serum autoimmune workup and anti-TPO antibodies and meningitis panel came out to be negative later in the day. So a multidisciplinary team discussion was done with the family in view of the persistent EEG findings of epileptiform discharges and use of triple anesthetic agents and AEDs and all. The decision was taken to medically terminate, suspecting whether this new onset refractory status epilepticus might be because of pregnancy induced. And later on the day, the termination of pregnancy was done. So this is the meningitis panel which we have sent. Here we could see all the bacterial, viral, and the yeast organisms has been negative. And in the CSF and the serum autoimmune panel, the report has been negative, and the NMDA, AMPA, GABA, LG1, Casper2, all antibodies has come out to be negative. So later, because based upon the lab findings of negative autoimmune profile and meningitis panel, we thought to withheld all the IVIG, steroids, and acyclovir has been withheld. Later, with triple anesthetic agents, with triple AEDs, we could achieve burst suppression on the EEG. And we thought after 24 hours, slowly to wean the infusion. So this was the EEG on day 8, where we could see burst suppressions with burst discharges with suppressed waves. And this was on triple agents of AEDs and triple agents of anesthetic agents. On day 9, when we were trying to wean off the anesthetic agents, again the EEG showed a continuous epileptiform discharges. So a 4th AED was added, that is injection lacosamide 400 milligram stat, followed by 200 milligram dual dose, and continued with the anesthetic infusion. And the plan was to get a MRI scan was done, which we can see there was no lesion or anything, and came out to be a normal study. On day 10, her GCS is E1 VT-M1. There is no response to the deep pain stimuli. The pupils are around 3 mm, sluggishly reacting. Her vitalis is stable. Later, because of the continuous epileptiform discharges, even on 4 anti-epileptic drugs and 3 anesthetic agents, a plan was to start her on injection thiopentone infusion. And the propofol infusion has been stopped after the 3 days and continued with other medication. And later, we started her on a ketogenic diet also. So on day 10, because of her prolonged ICU stay and mechanical ventilatory support, a tracheostomy consent was taken and tracheostomy was done. And till now, the EEG showed burst suppression till date. So this is the patient at present in our ICU. Who, as you can see, she's on triple anesthetic agent infusions, that is midazolam, ketamine, thiopentone, and continuous EEG monitoring, where you can see burst suppression on the EEGs with tracheostomy and the ventilatory support and ketogenic diet ongoing. And vitally, she is on stable with a minimum NORAD support because of the usage of these anesthetic medications. Thank you.
Thank you, Nithin, for a nice presentation of the case. I request Dr. Durgesh to go ahead with the presentation, and subsequently we'll have the panel discussion.
So, good evening, everybody. Thank you, Dr. Madhusudan sir, and thank you, Dr. Nithin, for bringing this wonderful case. Now, here we are dealing with the NORSE, that is new onset of refractory status epilepticus. So, like from going from status epilepticus, like if we define what is meant by status epilepticus, it is we have got a continuous clinical or electrographic seizures for more than 5 minutes, lasting more than 5 minutes. We label it as a status epilepticus. Or if there are more than 2 discrete seizures with there is no complete recovery in between these 2 seizures, there is no complete recovery of the consciousness, we label it as a patient to be in status epilepticus. So then come to the refractory status epilepticus. In refractory status epilepticus, the seizures continue in spite of having a patient is on at least 2 anti-convulsive medication with adequately dosed. One should be of adequately dosed benzodiazepines as well as long-acting anti-epileptic medication. Still, seizures are persisting, will label it as a refractory status epilepticus. Now comes super refractory status epilepticus. Now, in spite of using an anesthetic agent like continuous IV infusion of propofol or ketamine, the patient is having persistent seizure activity for more than 24 hours, then we label it as a super refractory status epilepticus. So coming to the etiology and how to investigate, to start with initially, a patient of status epilepticus, we should be having routines, what our CNS investigations. So starting from the any cerebrovascular accident, any serious infection, might be bacterial meningitis, might be viral encephalitis, toxoplasmosis, tuberculosis, neurocystic sarcosis, or patient might be having intracranial tumor, traumatic brain injury, hypoxic ischemic encephalopathy, or patient might be having any intoxication or in the withdrawal syndrome. These are the etiopathogenesis we have to consider while we are considering or evaluating a case of status epilepticus. Not only this, there are systemic infection, electrolyte imbalances, hypoglycemia, hyponatremia, hypocalcemia, hypercalcemia, hyperammonemia, ammonemia. These are the few things we have to consider. Chronic processes, any remote brain injury, encephalomalacia, or old because of old stroke, or patient might be an old trauma. These are the probably common causes of patient might present with the status epilepticus. Certain rare causes we have to consider like autoimmune disorders, any mitochondrial disorders, or any uncommon infection, or any genetic disorders. And here the comes when, in spite of all these investigations we did, and we are not coming to any conclusion, we have to consider a cryptogenic NORSE. So again, to start with the management of patient with having seizures or status epilepticus, again the algorithm goes: secure the airway, maintain the breathing and adequacy of the circulation. First, we have to give adequate dose of benzodiazepines, most commonly lorazepam, 0.1 milligram per kg body weight will give. Then still seizure persists. The second anti-epileptic medication, probably levetiracetam or valproic acid, appropriate dosage, exclude the routine common causes. Then still seizures are persisting, then we have to consider the anesthetic agents like propofol or ketamine in adequate dosage, and we have to start continuous infusions. So now discussing about NORSE, what is meant by NORSE? The syndrome which is seen in the adult as well as children. There is a new onset of refractory status epilepticus without any acute or active structural, toxic or metabolic causes occurring in the patient, whereas there is no previous history of epilepsy or any other neurological disorder which is known to precipitate the seizures. So previously there are different acronyms has been given to this syndrome. So FIRES, like febrile illness related epilepsy syndrome, commonly seen in the children, or previously they have been labeled as a specific in pediatric age group, devastating epilepsy in school going children, or sometimes it has been also labeled as a acute encephalitis with a refractory repetitive partial seizures. These are all the acronyms given to the NORSE. Now NORSE has been categorized. NORSE has been given the name, and these are all subtypes of the NORSE. The epidemiology, if you see overall, the case records are quite few. Overall, only 400 odd documented cases of NORSE in adult as well as in pediatric population. The incidence, like as the patient goes from status to super refractory to super refractory, the incidence of the NORSE like goes from 7 to up to 70%. In adult population, female is more commonly involved. In pediatric, male are more commonly involved. The mortality in adult is up to 27%. In pediatric population is up to 12%. So after initial workup, that includes initial lab reports as well as series of panel PCR reports. If the patient with initial culture reports are negative and patient is adequately dosed anti-epileptic medication, still the epilepsy is continuing, then we can label this patient as a new onset refractory status epilepticus. the etiology, if you see, almost more than 50% of the cases in pediatric as well as in adult population, the cause is not known. There we label it as a cryptogenic NORSE. See, and remaining up to 30 to 40% of the cases, it might be either paraneoplastic encephalitis or any autoimmune encephalitis. Rare infection causes up to 10% of the cases may present as a NORSE. The proposed mechanism why the seizures so refractory in the NORSE, especially this applicable in the pediatric population, is either any form of systemic illness or any acquired genetic disorder which predisposes to the release of the pro-inflammatory markers, pro-inflammatory molecules which are brain bound. So these pro-inflammatory molecules, what they do is they lower the seizure threshold and the patient will start having status. This status again causing more and more release of the inflammatory molecules, and this cascade goes on ongoing, and finally there is a tissue reorganization, and these kind of patient may land up, especially pediatric population, may land up in chronic epilepsy. Seeing this pathophysiology, that's what the immunotherapy is proposed in NORSE cases. So why we label it as a NORSE as a sometimes cryptogenic NORSE in more than 50% cases. So it is a new onset of refractory status epilepticus in previously healthy individuals. They are usually refractory to the conventional anti-epileptic medication, and most of the cases there is no etiology is found. Then there are certain scoring system to differentiate between cryptogenic NORSE and autoimmune encephalitis. They have been given. Usually, if the at least 5 or more than 5 points are present, then we can label this patient as a cryptogenic NORSE. The first thing is that they are highly resistant to conventional anti-epileptic medication. Previously, the individuals are healthy and there is no any history of seizure activity. And most of the cases, up to 50% of the cases, they may have a prodrome of high fever of unknown origins. So they may present between the seizures if the fever is up to at least 2 weeks prior or in between 2 weeks to 24 hours. They may present with the status after 24 hours of the fever onset. And there is no any prodromal, psychological or any memory alteration. And there is an absence of the orofacial or limb dyskinesia. This is more commonly seen in autoimmune encephalitis. There may be symmetrical changes in the diffusion weighted images in the form of hyperintensities. And there is no any well-characterized neuronal antibodies in this, both the serum as well as in CSF. And all the reasonable causes have been excluded. Now, if we come across such type of the patient, what we should do is we should evaluate in the form of routine our investigation like MRI brain with contrast, with probably MRV, with MR venography, routine our blood chemistries like serum analysis, autoimmune panel has to be sent, viral staging has to be sent, as well as CSF analysis has to be sent, including cell count, protein level, immunoelectrophoresis, and surface anti-neuronal surface antibody screen has to be also sent, and respiratory routine gastrointestinal panel, multiplex PCR panel has to be sent, toxicological screen in the form of benzodiazepines or any amphetamine, cocaine, alcohol, probably that has also to be sent. And coming back to the specialized circumstances, like in selected cases, in immunocompromised patient, we have to look for opportunistic infections and exposure to specific pathogens which may be responsible for encephalitis. Or if we clinical suspicion of paraneoplastic encephalitis, there we should go for a PET CT, pelvic ultrasound, and the MRI of that particular organ. And inborn error of metabolism, especially in the pediatric population, mitochondrial disorder, we may go for chemistries like LDH, CSF lactate, pyruvate, or sometimes muscle biopsy also indicated. Or any genetic disorder, we have to go for further testing. So as already known, most of the cases, up to 50% of the cases, the cause may not be known. So we label it as a cryptogenic NORSE. In up to 40% of the cases, it may be associated autoimmune encephalitis. So they are having up to paraneoplastic limbic encephalitis. Surface antibodies, commonly NMDA receptor antibodies, or voltage gated potassium channel complex antibodies may commonly seen in the population. Rare infection like enteroviral infection, cytomegaloviral infection, or any genetic disorder, including mitochondrial disorder, may also possible. So there is a often overlap in between cryptogenic NORSE and autoimmune encephalitis. It has been proposed that the underlying pathophysiology of cryptogenic NORSE it is a autoimmune process where we don't have a proper antibodies yet discovered. So that is why the immunotherapy is proposed while treating both autoimmune encephalitis as well as cryptogenic NORSE. But there is a few points to differentiate in between these two entities. In autoimmune encephalitis, there is a more prodromal psycho-behavioral changes, memory alteration, so which is not seen in the cryptogenic NORSE. Cryptogenic NORSE, the patient may present at a high grade of fever from unknown cause. CSF, you see, the oligoclonal man is commonly seen in autoimmune encephalitis, which is not there in the cryptogenic NORSE. So, immunotherapy is the first line of treatment in autoimmune encephalitis. So, the cryptogenic NORSE also, along with AEDs, we should consider the immunotherapy. Lesions may be specific in autoimmune encephalitis, but there are no specific lesions which points toward the cryptogenic NORSE. So coming to the EEG finding, as a literature suggests, there is no any specific EEG finding which points out to the patient which is having status which may goes to the NORSE. So especially in the pediatric population, they may have delta press, especially in NMDA receptor encephalitis. And coming to the MRI findings is also quite non-specific. To start with, most of the patient, they may not have any specific MRI findings. Sometimes as the disease progresses, there are some review of the literature. They follow the one of the patient with having cryptogenic NORSE. As the day progresses, you may see the hyperintensities in the medial temporal lobe. As the disease progresses, the hyperintensities will further worsen in the other areas like perisylvian areas or more of the completing involving temporal lobe. This patient has been started on the immunosuppressive therapy, IVIG, as well as cyclophosphamide. As the day progresses, the clinical condition is got better, as well as the MRI hyperintensity has significantly came down. So, if we are treating, encountering a patient with a status, then super refractory status, if we got an etiology, we have to treat as per the etiology. If we are encountering the cryptogenic NORSE with incomplete response to the anti-epileptic medication, then we have to consider immunotherapy at the earliest, at least in the first week of the disease onset. The immunotherapy is like IV methylprednisolone or IVIG or plasma exchange. Methylprednisolone like up to 1 gram per day up to 3 to 5 days in pediatric population up to 30 milligram per kg body weight. IVIG like 0.4 gram per kg divided into 5 days. And if still no response to the first line of therapy, we should be considering the second line of the therapy drugs like IV rituximab, cyclophosphamide, and the Ankindra. And if still not, ketogenic diet is also nowadays hold a promising results. So coming like the ketogenic diet, and there are some rare treatment that's been prescribed in the literature like deep brain stimulation and vagal nerve stimulation. But they are not still in common practice. These are the CSF findings, which is more commonly seen in autoimmune encephalitis. There is a presence of the oligoclonal band in the bands in the CSF, which is not there in the many probably patient is having NORSE or in normal population. So coming back to the ketogenic diet, it has been proposed that when the patient, especially in the pediatric population, so ketogenic diet, it is a basically high fat, low carbohydrate and adequate protein diet. So it has been the theory behind is the fatty acid or the ketone bodies which is generating from that, they have a anti-seizure potential as well as a glucose stabilization property. And they keep the neuronal membrane in the hyperpolarized state. So the excitatory neurotransmitter action as well as the release is decreased, and there is a increased inhibitory neurotransmitter. So the seizure activity somewhat reduced. So, but while giving the ketogenic diet, it is always to be given under medical supervision. Any physician as well as dietitian should be continuously monitoring patient on the ketogenic diet. Again, there are the certain complications which are there in the ketogenic diet, like the patient may develop hypertriglyceridemia, acidosis, constipation. In long term, the pediatric population, they may have developmental disorders, vitamin deficiencies, and growth retardation is also possible. So as you see, there is a high fat and low carb diet. So this palatability of that is very questionable. So the other diet is medium chain triglyceride is being proposed. The fatty acids, the ketones produced by the medium chain triglyceride is much more as compared to other oils. So there is a space to accumulate the extra carbohydrates. So the palatability can be improved and the patient may be able to tolerate the diet well. But again, whenever we are trying this kind of diet, the patient should be under continuous physician and dietitian supervision. So then coming to the prognosis, the patient is usually having this kind of the patient is usually having super refractory status epilepticus. And as you see, the patient should, they usually have a prolonged ICU stay. And as a prolonged ICU stay, they will end up in different complications and usually have a poor outcome. The patient usually fires in pediatric population. They may land up in chronic epilepsy. And the long-term cognitive impairment, they will have a long-term cognitive impairment. They will be mostly dependent in others, and the functional recovery is also incomplete. And they will be, other thing is that family counseling is also most important. Many of the patients, they may not be parents, they may not be knowing the disease entity. The acceptability in the general population is quite less. And the prognosis, if we see, is not very good. So the frequent counseling of the patient's family is quite important. Thank you.
Thank you, Dr. Durgesh, for overview about the NORSE. To take it further, we have the expert panelist, Dr. G.V. Subbaiah Chowdhary, sir. He is a senior neurologist and the clinical director of neurology for Yashoda Group of Hospitals at Hitec City. Welcome to you, sir.
Good evening. Good evening to everybody.
Thank you, sir. Thank you. And we have the second eminent panelist, Dr. Sai Satish, sir, who is the consultant neurologist and epileptologist at the Yashoda Hospital, Secunderabad. Welcome to you, sir.
Hello, everybody. Good evening, sir.
Thank you.
Good evening.
So that while proceeding further about the discussion about the NORSE, just wanted to ask about Subbaiah, sir, what is your experience in day-to-day practice about the refractory status epilepticus, sir?
Yeah, refractory status epilepticus we see in our practice, but NORSE is not very common. I think this is the fourth case I have seen, but previously when before that one, the term NORSE was actually, it was coined recently after 2018, I think so. So previously we used to treat with, because the patients are not responding, that time we just used to treat with steroids because of the basing on the backup of the literature. I still remember one case which stayed with us for almost 45 days. We gave 2 cycles of methylprednisolone and patient recovered. And if I remember, this is the 3rd or 4th case. But this time she's in a very, she's not responding to IVIG. She didn't respond to steroids or IVIG. So right now she has mild fever. So that is the status right now.
Thank you, sir. As you told about, I think the coming to the diagnosis of this is quite rare, is not very common, and not sure about what medications she'll respond, because it's quite difficult in spite of giving so many medications, the patient not responding in spite of having so many gadgets also.
Yes.
So Saitadi, sir, like this patient which is coming, normally the patient coming to the intensive care unit, we see the patients are coming with a seizure activity. How we come to the conclusion in our day-to-day practice? I think Nithin and Durgesh has explained well about so many patients having the seizures, the EEG monitoring and everything. I think for each and every patient which coming to the ICU, we don't do an EEG for the patient, we start empirically. I just wanted to, for the benefit of the students and everything is there, what is your approach for starting the treatment for these patients to treat?
Sir, it is quite important to get an EEG, sir, new onset refractory status epileptic doesn't mean only the convulsive seizures, but there might not be non-convulsive seizures as well. So the only way we can diagnose non-convulsive seizure is with the help of EEG. And this suspicion of having continuous non-convulsive seizures should be there in mind, despite controlling the convulsive seizures. So in any patient who had convulsive seizure, and we expect them to regain their consciousness and they become oriented within 15 minutes in a general routine scenario. So any person who had a seizure but not returning back to the baseline after generalized seizure, it is quite important to rule out non-convulsive seizures. That is only possible with EEG, that we have to get it. And as you said, sometimes at midnight, sometimes because of many logistic reasons, it might not be possible to get it done. But still, we need to consider treating non-convulsive seizures as well. So, regarding like how to treat non-convulsive seizures, as like Durgesh sir has quite nicely elucidated, we need to initially start with the first line of anti-epileptic agents. And it has been observed that the initial dose which we give at the first seizure, that determines whether the person will have recurrent seizures or not. Many times we see in our ER, when some person has a seizure, it is irrespective of what the weight of the person is, they give 1 gram of levetiracetam or 1.5 gram of levetiracetam. It's not like that. We need to load with 50 to 60 milligram per kg body weight. Let us say some 50 kg or 60 kg person is there. We need to give full dose. You hit it hard the initial step itself. Give 3 grams of levetiracetam. So many a times it has been observed that only when we treat it suboptimally, maybe a few people tend to have good control of seizures, but those going into status, probably this is one of the reasons why they probably have recurrent seizures. So when we encounter or when we receive some person with recurrent seizures, the first thing we may need to make sure to see whether that person, whatever medication that person has received is appropriately loaded or not. So let us say he is on levetiracetam or valproate or lacosamide. We need to see how much dose has been given as a loading dose. So if it is like suboptimal for his body weight, then probably we need to load it. And once some person has recurrent seizure despite loading with 2 IV antiepileptics, and they fail benzodiazepine also, then that is the time where we have to be quickly resort to IV anesthetic agents, because waiting for another seizure might not be a good idea, because the more the time we give for the seizure to perpetuate, the more the circuits it recruits and the stronger it becomes. And as we have many pathophysiological studies, they show that initial 5 to 10 minutes is where the GABA receptors are on the surface. Once the status sets in, becomes refractory, the GABA receptors are internalized and all the AMPA receptors and NV receptors, excitatory receptors are expressed on the surface. So we need to use such kind of medications where they specifically target those excitatory transmission as well.
Thank you, sir. I think you raised the important point is there. Most of the people which coming with some form of seizure activity is there. It is a knee-jerk reaction in the emergency room to give around levetiracetam injection or levipil injection only 1 gram. I think that is the not correct. The way of practice is there. In the same way, like any antihypertensive medications we go to the full of the dose. Because that itself will indicate about whether the person is going to react in the future or not. One of the just for completion's sake about Subbaiah sir, one of the attendants asking about what is the sequence of medications we follow. Is there any sequence of medications we follow if the patient we given the anti-seizure medication? Is there important rule is there we have to follow in the sequence 1, 2, 3? Or we require an IV medications are there and subsequently patient not responding to that medications, we are giving to IVIG or methylprednisolone.
Yeah. So you mean the first when the patient comes, as Dr. Sai Satish told, the benzodiazepines play the major role. So whether you give lorazepam, whether you give midazolam, or whether you give diazepam. In that one, order of preference is lorazepam because it has a long half-life. Pre-hospital management, maybe midazolam because you can give it IM. So some of them, they prefer diazepam because they have in the kits, it is very stable. So in the ambulances and all, you can keep midazolam or diazepam because you can give, because they are stable solutions. Once they give lorazepam, it's long half-life because of its long half-life. And if there is a repetition of the seizure, we can give another dose of lorazepam. Setting a part of it, unless some temporary seizures like hypoglycemia, better after giving the lorazepam, you go to one of the main important anti-epileptic drugs, like whether it's a levetiracetam, whether you give it a phenytoin, or whether it's a valproic acid. So either one of the three you have to give. Of course, they have some relative contraindications in this one. Suppose if the patient is having some primary generalized epilepsy, you can go directly for valproate like that. Or sometimes, I mean, instead of phenytoin or phosphorynthine, people prefer levetiracetam. As levetiracetam, all the three drugs are almost equally potent, or I mean, equally safe. You can, I mean, equally potent, you can give one of those drugs. So once after giving the drug, if they have a seizure, they say to repeat with lorazepam, then add another anti-epileptic apart from those three. Whether you give first levetiracetam, you can give sodium valproate, or you can give other drug. And sometimes what they prefer is to give phenobarbital. Next level, they give phenobarbital. Previously, they used to give phenobarbital because levetiracetam, they used to give phenytoin, then half-loading phenytoin, then they used to give phenobarbital. Nowadays, they say you can give either one of those three drugs. Next, followed by, if the seizures still continue, you can add one more anti-epileptic drug. Suppose if you give levetiracetam, you can give phenytoin, or you can give sodium valproate. After giving that also, if you have still, then we call it as it is going into refractory, then we can go into the IV anesthetic drugs. In the IV anesthetic drugs, you have three drugs. One is IV midazolam, next one is propofol, and next one is thiopental. And unfortunate, somebody raised about ketamine. So the main thing is, what they say is all these three drugs, they act on the glutamate receptor. So they act on the GABA receptors. So as they act on the GABA receptors, and midazolam is the safest medication, they prefer midazolam. And still some of them, they feel that propofol is ideal, and some they feel that thiopental is ideal. But the problem with thiopental is it's hepatotoxic and it produces hypotension. And now the latest argument what is coming is, in the IV anesthetic drugs, once you try midazolam, maybe you can go with the ketamine, because ketamine is the only anti-epileptic drug which acts on NMDA receptors. So then by this time, if the supra-refractory status sets in, maybe then you can give ketamine. I mean, there is no exact fixed line. So you give lorazepam, then you give phenytoin or levetiracetam or sodium valproate, then you give one of the drug, then you give one of the IV. Sorry, I'm repeating the drugs again. You can give the other three drugs, one of the drugs like propofol or midazolam or thiopental. Then some of them, they bring ketamine in along with the midazolam. So this is the order they follow. And of course, apart from this, the disease-modifying drugs like immunomodulating drugs, you give IV methylprednisolone. Suppose if you think it is autoimmune encephalitis, for excluding infections, then you come with the IVIG or plasmapheresis. Some of them, they feel that still plasmapheresis is superior to IVIG because the onset of action is mainly a little bit rapid, they say. But still, they have a lot of arguments between whether plasmapheresis is preferred or IVIG. The next step is, then after when these two drugs are failed, so see for the inflammatory markers. If the inflammatory markers are elevated, better go for the Akidra. Then, or otherwise, whether it is a rituximab. And most of the experience are with rituximab. So likewise, they follow like this. I hope I'm clear. If anything is there, I would share this one.
Thank you, sir. For disease, we should have systematic approach is important.
And one more thing, just I want to add, as Dr. Sai Satish said, that you have to hit it hard, correct. But still, some of them, what they feel is, most of the patients in the ER, they give levetiracetam 1 gram, and most of them, they respond well. Only few of them, like 20% of them, they go into this refractory status. So which patients to give high dose, which patients to give less dose is little difficult. One. Second thing is, still some of them, they raise a point that levetiracetam after 1 gram, it may not work that much, because they say that 3 grams or 1 gram. I mean, there are some people who take this stand also. I also agree with Satish that you have to be, we have to be as aggressive as possible initially itself with benzodiazepine drugs, and then giving the IV loading doses of anti-epileptic drugs.
So that important thing is about making the diagnosis, whether the patient having a simple seizure, maybe because of some underlying causes there, or patient having status. And if the patient status is not responding in spite of medications, going to refractory status, that is the sequence of events, what medications we give. Is not an definitely you have to give the sequence of 1 to 3. And important things to understand, you have to rule out the underlying causes. What is the causes for the seizure? I think my colleague is there, Dr. Misra, who is the heading the intensive care medicine at Yashoda Hospital, Somajiguda. Dr. Misra. Kindly unmute, Misra, unmute.
Yeah, good evening, everyone. Sir, I think the discussion is going nicely. I'll just ask one practical question, sir. Either Subbaiah sir or Sai Satish sir can explain, just answer. Let's see, when it comes to a suprarefractory or a refractory seizures, we are adding some anesthetic drugs like your midazolam, propofol, maybe thiopental, what we don't use that commonly, and maybe ketamine. Most of the time, as Subbaiah sir told, we are starting with midazolam only. And the dose, if you see the dose of midazolam, which goes from like 0.2 mg per kg to up to 2 or maybe 5 mg per kg also. So at what level, like let's say we started midazolam, at what dose we should believe that we should add a second dose, or where we should think that this is not working or this is not helping the patient, and we should add the second drug. And what will be the ideal second drug when you are using? Is it a ketamine which acts through a different SR told all these things are acting through GABA? The second drug should be what? Actually propofol, thiopental or ketamine. And like every time when we are adding something, we should hit the different receptor, or is it okay to give midazolam then propofol? And at what dose of midazolam we should add the second drug?
Technically speaking, what you said is right. I think we should prefer the drugs which acts on different receptors, because NMDA receptor antibody mediated NORSE is quite common. Of course, cryptogenic is still 70%. It's only 8 to 10% among the autoimmune. So NMDA receptor is quite common. So probably ketamine and one of those 3 drugs would be ideal. Now people are, because of midazolam, its safety more safe, so they're using quite commonly midazolam. But I think now still some people are very comfortable with thiopental, though it is very, though it has a lot of hepatotoxicity, cardiorespiratory depression. So if you see so many, if you go back to the literature, because which we are doing again and again, so we see first after those 3 drugs, they start ketamine. But here also in our case and in other case also, after giving ketamine, they started giving another anti-epileptics like propofol, then they gave lacosamide, then they gave perampanel. And various case reports are coming up with they are responding again, duplicating one more drug. Whether it is because of the combination of the drugs or the second drug which is given is helping out, nobody is clear about it. And even some cases, they say that when they found that after terminating pregnancy, seizures have been terminated. Seizures also have come down after 3 days. Whether how much is true, it is difficult, because NORSE per se is, it is very rare entity. I think still guidelines are yet to come. I believe we should give drugs which are acting on different receptors. What is it,
Sai Satish, sir?
Yeah, I completely agree with what Sir has said. And this is an area where we have a dearth of data. We do not have any specific guidelines or anything. And here, we, as Sir said, like combination of medications works good. Since we know that once status has set in, the excitatory transmitters are very much exposed and the GABA receptors are internalized. My preference would be starting both simultaneously, midazolam with ketamine combination. And I would not wait for midazolam to act to see for some time and then add the second one. I would actually start simultaneously and I escalate both till the time I reach the burst suppression. That is our ultimate target. Either you start with single medication or a combination of medication. First target is controlling a convulsive seizure. The second would be non-convulsive seizure. And third would be attaining burst suppression. So once you can attain burst suppression, like it might depend like how much milligram, how much dose of midazolam or ketamine one person needs to attain burst suppression. So our target should be attaining burst suppression or till the maximum dose which can be tried for one agent, or till the maximum dose which a person can tolerate. Like as we know, all these medications can cause hypotension. We can still manage within the inotropic support if it is achieving burst suppression. So that is a target. So if at all we are starting one medication, let us say midazolam, that also we need to give loading dose and then start. And they say around 0.2 milligram per kg of midazolam should be ideal. And then start and go up to like maximum of 1.2 milligram per kg per hour infusion. So we can actually wait for probably like there is no specific time, but roughly around 5 minutes to see if there are any convulsive seizures or non-convulsive seizures, or we have attained burst suppression or not. These three, and then we gradually escalate the dose till the maximum dose which the person can tolerate. So this is how we start IV anesthetic agents.
So in these cases, like anyway, the drugs we have discussed, and I think Dr. Nithin, what he has presented is that lady was pregnant, isn't it? Have you tried magnesium sulfate, and what is the is there any possibility that patient can be having eclampsia which triggered a NORSE kind of thing?
We have given her magnesium sulfate, sir, as a loading dose. And initially when she came, her BP was also on the lower side, and we looked into her 24-hour urine protein creatinine ratio, which was also less than 300, to screen for any preeclampsia features. And previous her antenatal history, previous obstetric history also, there was no...
Eclampsia can be there without having preeclampsia, isn't it?
Yes.
Yeah, Dr. Nithin, I think eclampsia was excluded, preeclampsia also, and that too, this is 15 weeks pregnancy, right? Most of the times it is after 20 weeks.
15 weeks.
It's 15 weeks pregnancy, no?
Yeah, 16 weeks is rules out, sir, actually.
Yeah.
Without reaching 20 weeks, we cannot say only.
Yeah.
Regarding our, even the data is there, regarding your inhalation anesthetics, like let us see isoflurane and all those things.
Yeah.
Like what is the practical experience regarding this inhalation anesthetics in NORSE cases?
Oh, you are asking me and Dr. Chowdhary. Yeah, I don't have any experience, honestly, regarding inhalation anesthetics, because I don't have experience on this inhalation anesthetics.
We haven't tried English anesthetic once here in Yashoda setup, but during our training and epilepsy fellowship, we had a couple of cases managed with isoflurane. But the outcome was not very good. We can attain burst suppression, but once you come down again on the MAC of isoflurane, the seizures used to return back again.
So only one
thing there you need, sir.
Yeah, please go ahead, Satish. Sorry, please go ahead.
Nothing, sir. I have given my point.
Yeah. Do you feel that there's a controversy, whether to go for burst suppression or just termination of seizures is enough?
Yes, sir. I still that controversy is still there, sir. But many times we see that patient super refractive status, though they are like seizure free electrographically also, sometimes we may not accept burst suppression at all. Despite how much high we go on IV anesthetic agents, there are few patients we hardly attain burst suppression. So in this patient, we see that they are seizure free at least for 12 to 24 hours electrographically, and then we gradually wean off from IV anesthetic agents.
Yeah, practically you go see the literature, they say that just abolish of the seizures enough, no need of burst suppression. But ideally, I also feel that, attaining burst suppression will feel more secure. We also, that means the seizures are getting controlled well. But at the same time, the interburst interval is lasting too much also, we'll also be worried whether the brain is not responding. So the other side of it, we will be worried whether it is going into anoxic injury and all. What do you say about that?
Yes, I completely agree, sir. Yeah. Even this burst suppression also, how much of burst is accepted, how much of suppression, duration of suppression is also a very debatable issue.
Yes.
The degree of burst suppression, how much and to how long also is a debatable issue. I completely like. There's a very gray areas.
Yeah, correct.
Yeah.
Actually, just to share one similar case what we had recently at our unit. Actually, a young fellow who is a known epileptic presented to us with starters. So everything came out to be negative. Then we continued one after one anti-epileptics. Things never improved. In the meantime, he was continuing to throw seizures. Maximum doses of like propofol, midazolam, ketamine, all were going on. After I think 5 or 7 days, we repeated one more MRI. And that MRI was showing necrosis of the brain. Like how frequently we see something like that, and how frequently, or like, is there any guideline when we should repeat any neuroimaging? Let's say initial neuroimaging is normal, then when we should repeat a neuroimaging in cases of this refractory or supra-refractory status, and how it is significant?
Actually, there are no guidelines when to repeat the imaging. So when we repeat the image and again next we repeat the image, the same thing, because sometimes we see the post-ictal changes in the medial temporal lobes, and initially something like, even if antibodies, how many times we see antibodies positive? So sometimes even if the antibody is negative, we can see the medial temporal lobe changes where we can have limbic encephalitis or other autoimmune mediated. Sometimes you may see the changes. But unfortunately, it is sometimes difficult to differentiate between these autoimmune changes versus post-ictal changes also. So that I think there's no need of repeatedly repeating imaging. That's what I feel. But definitely, if there is something, any deficiencies there, other things, we want to see what is the follow-up and all. It may, I think that in that scenario, we may repeat it.
Yes, sir, I completely agree with you, sir. So, sir, imaging, once it's initially normal, as sir said, repeat imaging might show some flare hyperintensive mesial temporal lobe or so-called the insular cortex and all. But yes, person who has generalized seizures, let us say a couple of days later, he continues to have only focal seizures. EEG also shows only seizures on restricted to only one side, are emanating from only one area, and that is difficult to control. And rarely if the seizures are generalizing from that area. So probably at that point of time, we can still considering repeating an imaging. If imaging is negative, very rarely we can resort to PET studies also. If we can actually localize with functional studies and hypermetabolic region in a focal region which is resectable. In very rare circumstances, I have seen only one case which we had done frontal lobectomy for refractive, super refractive status epilepticus, but the child did not survive. That's the other part of the story. But considering repeating imaging, I think if there is any focality, either clinically or electrically, it is worthwhile repeating an imaging to see if there is an anatomical substrate to that particular seizure semiology.
Sir, one question and one doubt. I like going through the literature, what they have proposed that whenever you are dealing a case of NORSE, initially radiological finding, many times you may not find a specific finding. As the disease progresses, then you may have a changes in the, like, as you said, temporal lobe or peripheral fissure, whatever like this. So these, like, can they point out towards any autoimmune etiology or any cryptogenic etiology?
Yeah,
No, sir.
most of the times. Yeah, go ahead.
Sorry,
No,
sorry, sir.
go ahead. Go ahead.
No, I was just trying to tell that any generalized seizure, these are the common areas. Usually they like hippocampus is very sensitive area. Generalized seizures, we tend to see bilateral hippocampal hyperintensity. So I think initial MRI normal. Later on, whatever changes we see, mostly they are quite non-specific, I would say.
Yeah, what you said, I mean, after, see, the here main thing is the purpose of repeating imaging field is to exclude autoimmune. But when we see a NORSE case, the first thing what it strikes our mind is whether it's an infection or an autoimmune. So by the time we plan to do the repeat MRI, we will be already starting these immunomodulators. So that's the thing we have to remember, that one. And of course, when in-house, there is no contraindication to do the MRI unless patient is very unstable, I feel. I mean, definitely, if you want, you can. I mean, sometimes attendants will be pushing also what is happening, we want to know. So I think this is a flexible thing. This need not be a hard and fast rule. That's what I think.
Sir, like regarding immunomodulators, no, sir. Anyway, most of the time we start with pulsing steroid.
Yes.
After that, we have three things. Let's say one IVIG, second is plasma exchange, the third is rituximab.
Yes.
So how will you like place them, sir? First, second, and third?
Actually, there are no guidelines. The I think methylprednisolone is the commonest one, cheapest one, and I think it covers both the B cell response and T cell response. So I think methylprednisolone would be ideal. And regarding IVIG or plasmapheresis, I still feel that if patient is stable, maybe given a choice, I would go for plasmapheresis. But they don't. I mean, it always they don't prefer one or the other. But here in these cases, they preferred IVIG or plasmapheresis. But to me, given me a choice, I would prefer plasmapheresis. And the third thing is whether to go for rituximab. It's once again, I'm not. I mean, I think the immunologist should say better than this one. It's only going to affect the B cell response, right? It's the other inflammatory markers. It may not work on it also. So some people try tocilizumab also. So I mean, IV methylprednisolone, then IVIG, then rituximab. That is my choice because that Anakitra is not available in India.
Yes,
What do you say, Satish?
Yeah. Yes, sir. I also completely agree with you, sir. Solumedrol, IV solumedrol is first line, and then between IVIG and plasma exchange, I think IVIG is the one which I prefer, sir, because one it is it is very easy to administer. One thing. Second time, I think by the time even if status patient is, if they are having some sort of sepsis and all, I think IVIG is better. And coming to plasma exchange, I have some reservations with that because many of the anti-epileptic medications are protein bound. Once you do plasma exchange, the levels like go haywire. So if at all we are resorting to plasma exchange, then I think after plasma exchange, we need to again reload with medications and all. So that is a very tricky issue. Given that scenario, I think my choice would be solumedrol with intravenous immunoglobulin. And rituximab, I have never used till now, frankly speaking, because since again it's an anti-CD20, the concern regarding the immunosuppression is a concern.
Yeah, the way I preferred plasmapheresis, the reason is very simple. One, I thought it's a real disease modifying agent. I mean, of course, the IVIG is always safe and also it's easy. There's no doubt about this. Especially in this type of cases, maybe IVIG is more preferable than plasmapheresis, especially in pregnant ladies. And as you said, these drug modifications will be there. But my only hope is once you give IVAG, you cannot do plasmapheresis. But once you do plasmapheresis, if patient is not responding, probably you can give IVAG also. That's the main, logic in my preference. That's what I
Completely agree with this.
Yeah. And one more
I
thing.
always believe plasma exchange is underused, sir.
Yeah. And one
So
more
if you
thing,
see-
in this case, I want to tell you is actually magnesium doesn't have role in this case because it doesn't fall into this eclampsia time. And patient is basically gynecologist prefer this one, and there's no need of objecting it. What we thought, because some people they tried giving IV Maxelf. So that is one thing we also thought. Okay, let them give it. That's what one. And one more thing is now recent trials that it's promising, and initially afterwards the other one is allopregnanolone. So this is one what they say is this is a very interesting drug. So most of the benzodiazepines, as Satish was telling, these GABA receptors, they internalize and NMDA receptors come out. So this is at the synaptic level. If you try allopregnanolone, what they say is extra synaptic GABA receptors will be activated by allopregnanolone. So they tried some of the patients who were kept on thiopentol or pentobarbital, and when they are withdrawing, when they had refractory seizures, they tried this allopregnanolone. So some of the people they tried this one, they had a good experience, but somehow in some trials it was not very successful. I think that is one of the some few case reports were about this interesting. This is nothing but a metabolite of progesterone.
Thank you, sir. Actually, some of the attendee has put a case. Actually, they are having some cerebral palsy case, patient having an paralytic ileus. Instead of giving oral medications, initially he's asking what are the drug of choices. What we discussed about the IV medications are there, whether we can give IV medications when the patient having paralytic ileus or clonazepam or clobazam. What is your opinion, sir? Subbaiah, sir.
Yeah, tell me please. I didn't. In case of paralytic ileus.
No. See, one of the attendee has put an case. Is having 17-year-old girl who is having cerebral palsy on oxazepine, and she was on the vagal stimulator implanted 3 years ago. Admitted because of aspiration pneumonia, and she's having paralytic ileus. He's asking the patient which is came now whether to give, because paralytic ileus they are not able to give oral medications, whether to give IV medications, and what is the preference?
So what were the drugs she was taking prior to it? If they are IV available, I think we can continue the same medications if it is not status.
Okay, thank you. I think
and clonazepam is not available. IV clonazepam is not available in India.
Hello.
Hello.
Can I say something, Dr. Manimala here?
Yeah, yes, ma'am.
Yes, ma'am. Please go ahead, ma'am.
Hello, everybody. I just thought, can you hear me?
Yes, ma'am. We'll be able to hear you.
Yeah, I just wanted to share that sometimes these, whether non-convulsive, mostly it is convulsive supra-refractory seizures, which we get in ICUs. We found one of the causes was also marijuana. I have published this, paper. In a young boy, we had seizures for almost a week. We tried everything. He was intubated. We looked into everything almost about 4 or 5 days, tried everything. And finally, I gave ketamine. And the nystagmus, which was there, immediately settled. Actually, what they say about ketamine when you're all discussing about the anesthetic agents, I would like to say that when you have super refractory, whether it is convulsive, non-convulsive, when you have these seizures for a long time, the GABA effect goes away. So even if you're trying to inhibit the GABA, it doesn't work that well. So usually this NMDA receptor, and especially if the rare cause of this marijuana, which is, the commercial marijuana, people are using it. So just keep it in mind. I just wanted to tell you all. Okay. And isoflurane did not find a great, improvement to do the seizures. It comes back as you stop it. So that is another thing which they have found. So you can use all these drugs one after the other, but keep ketamine in your mind when the seizures are refractive. It's a fairly 1 milligram kg bolus, and then you start off as an infusion, and then slowly cut down as the seizures come down. And another important in the ICU, I feel that when you have these seizures, have the BIS monitor. So it gives you a lot of this thing. I always used to use it. So these are a few things I just wanted to share. So I stayed back. Okay, bye. All of you. Nice hearing to all the good conversation and panels. Okay.
Thank you, madam. Thanks a lot. Thank you. Because already we are crossing the time at 8 o'clock.
I just wanted.
Thanks a lot, madam. Thank you. Just we are crossing the time of whatever discussion for last almost hour and so. Just wanted to take home message from Subbaiah sir from this. What we want to give that a lot of people are attending. I think more than 80-90 people are online, and a lot of the people in the hundreds and thousands of the people subsequently will follow about what we are discussing, and that will be practically useful. What you want to give the take home message from this session for the NORSE, sir?
So NORSE is not very common, one thing, and here bedside EEG plays a very important role in treating these patients too. And as Satish told, we have to initially, we should not give under dosages, we should give proper dosages for these things. And most important thing is we should not give up, because most of them are young female patients, and high index of suspicion regarding autoimmune should be there, and exclude infections. And I think you have to be teamwork, aggressive approach, and always keep the attendance in confidence that what we are doing it. And first of all, we should not treat with underconfidence. That's what I feel. And I should really thank the attendants for their lot of cooperation in this case, because we are also not trying to, especially our critical care team also doing a good job. So I think we should not give up. We should keep trying. I hope will come out. I hope she will come out.
Thanks a lot, sir. Thank you. Dr. Sai Satish Garu, what do you want to give take home message?
I have nothing more to add to what Subbaiah sir has said. High index of suspicion, hit it hard first as soon as possible. Never give up hope. I think we need to work as a team, and we need to have very low threshold to start IV anesthetic agents. We should not say that, okay, let us wait for one another seizure and all. So we should be treat it as a stroke. So like they say, time is brain, not only in vascular pathology, even electrophysiologically also. So we need to be fast, never shy away, and be optimistic.
Misra, I can take over for closing remarks.
Just before closing, I just want to ask the final thing, actually practical again. When we start, let's say multiple, in this case, patient is on, I think midazolam, ketamine and thiopentone. And maybe since last 10 days or 12 days, persistently she is having seizures. So let's say it is tomorrow it's getting control or burst suppression achieved. And how we should win, and which should be the first drug to win?
In this one, there's no doubt that we are going to win off midazolam. It was already started. The reason is midazolam and thiopentone act on the same receptors, and definitely when it was not working, whatever it is burst suppression we achieved with thiopentone. Second thing is ketamine, we are not ready to take out right now, because ketamine, except mild metabolic acidosis, it doesn't have that great side effects, because it's not going to produce hypotension. On the contrary, when you are giving the drugs which are producing hypotension, this drug doesn't produce hypotension. In fact, it will produce little hypertension also. So I think first drug we'll take out is midazolam, and if she is stable, I think we'll go with the ketamine. Probably we'll go next is thiopentone. That's in the order, or we may change. But first thing is we will taper off midazolam, and remaining those two drugs, I think probably we'll go out with ketamine, because she didn't respond initially to ketamine. And there were some patients who were ketamine for prolonged days, 8 days like that. So that was the reason we thought we'll go next with the ketamine. What do you feel, Satish? What is your input regarding this one?
Yeah, completely agree with you, sir. The midazolam is the first one which has to come out because we see after 24 to 48 hours.
Tachyphylaxis will develop. Yes. Yeah.
Sorry, sir.
Yeah, anyway, tachyphylaxis or internalization.
Yeah, tachyphylaxis. Exactly. I was just about to tell that one. Tachyphylaxis is the one which can be observed with midazolam after 24 to 48 hours. So I think midazolam is the first one which we need to wean off, and then probably then ketamine. Yeah.
Madhu sir, you can give your closing remarks then.
Okay, thank you. So still some of the people asking the questions. I think about the doubt about giving magnesium sulfate, Subbaiah sir has told, because in the pregnancy, when we are thinking about the patient having an eclampsia, preeclampsia, that is the drug of choice is there. Some of the people asking the question in the present case, which is their pregnancy, is the trigger factor for NORSE, or by termination of the pregnancy, patient should improve? I think is $1 million question. Sir can add anything. Subbaiah sir, you can add.
Termination of pregnancy. See, some people say that pregnancy, it will protect from epilepsy, right? So, but sometimes some of the case reports they found during epilepsy. Of course, the other thing is there. Why seizures may increase in pregnancy because of the hemodilution of the drugs or missing of the drugs. Those are the reasons, rather than the pregnancy itself inducing seizures. But if you see in some NORSE case reports, they commented that they terminated the pregnancy and third day seizures got decreased. And how sure is the termination of pregnancy or because of the other drugs were there, seizures have come down? I think it's difficult to answer, honestly speaking. I think I got the answer. I think I told you the answer. Second thing is magnesium sulfate. Once again, it is not going to prevent seizures. Once eclampsia started or preeclampsia started, you can give a trial of magnesium sulfate, and if it doesn't work out, you can go for phenytoin. But in this case, this is not a case of eclampsia or preeclampsia because it is still 15th week, and they did still, gynecologist, our consultant has excluded those conditions, and then, but still they want to give it, and there were some case reports where they tried with magnesium sulfate. So because of all these so many issues are there, we also allowed, we also didn't object to give magnesium sulfate in this case.
Thank you, sir. One more question was there about the ketogenic diet, completely avoid dextrose. And if in emergency they start an IV dextrose, whether it will precipitate the seizure or what? Sai Satish Garu. Kindly unmute. Sai Satish, kindly unmute.
Sir, I really don't think so, sir. Person who is on ketogenic diets, just because we don't with dextrose, it doesn't trigger seizures. No.
Thank you. Thanks a lot. Thanks a lot, Nithin, for presenting a wonderful case. He has generated so much of discussion. Thanks, Dr. Durgesh, for giving overview of the NORSE in nutshell, because it's quite difficult topic to understand, and a lot of people had doubt about the sequence of medications to use. And thanks a lot, Subbaiah sir, for taking out from time from your busy schedule and OP and giving your valuable opinion. Thanks, Dr. Sai Satish Garu, for giving an important information about using an EEG and the other medication what to use, and not less, Dr. Misra Garu, for supporting me for conducting this program. Thanks a lot.
Thank you, everyone. Thank you.
Thank you, sir.
Thank you. We'll end the program here. Thank you.